Good morning, everybody. I'd like to welcome everybody to this wonderful Epilepsy Week webinar presented by Professor Jo Wilmshurst. Professor Jo Wilmshurst is Head of Pediatric Neurology at the Red Cross War Memorial Children's Hospital. She's a Director of the African Pediatric Fellowship Program and Chair of Africa for the International League Against Epilepsy. I'm Charlene, for all of you that don't know me, lots of you don't, and I'm the National Director of Epilepsy South Africa. I thought my camera was on. I'm the National Director for Epilepsy South Africa, and we are a leading chapter of IBE, which is the International Bureau of Epilepsy. In Africa, IBE is an international organization and partners with the ILAE, from who Jo is the chair lady of Africa chapter. So why this week is special? So this week is special because it's International Epilepsy. It was International Epilepsy Day on Monday, and celebrating people with epilepsy around the world. Epilepsy South Africa runs International Epilepsy Day for the week, so we call it our National Epilepsy Week. And this week is about stamping out stigma in South Africa as well as globally. It's a global theme, and truly celebrating and sharing the lived experiences of people with epilepsy. Now, we know about the critical need for education and to break the stigma of epilepsy. As we know, to stamping out the stigma, we need to share more and more information as we can. So in the light of that, in the spirit of that, today is all about that, with Epilepsy South Africa in partnership with Netcare, of hosting this wonderful webinar for which all of you have come today, and thank you for joining us. And welcoming and thanking Professor Wilmshurst for giving of her time, her preparation time. We know how busy you are, Professor Wilmshurst, and so thank you very much for these moments. And to Netcare, it is a huge milestone for Epilepsy South Africa to be partnered with Netcare or the likes of Netcare. And we'd just like to acknowledge Netcare and Mandy Tolkien for creating this wonderful webinar today and the wonderful advocacy that is happening this week from Netcare supporting people with epilepsy. So Professor Wilmshurst, that's enough from me today. Once again, welcome everybody, and we look forward to hearing from you. Thank you, Professor Wilmshurst.
Thank you, Charlene, and I'd like to say thank you very much to yourself and Epilepsy South Africa for the vision and the drive to promote all the work that's been happening during this week, but also in recognition of all the work that happens all year round, and that has been an ongoing exercise to really approach better care for people with epilepsy, both on a medical level, but also on a holistic and a lifestyle level. And also thank you to Netcare for actually enabling this to happen. So the topic that I was asked to talk about is actually really important because it's one of the biggest drivers of probably our emergency department load for children presenting, and this is febrile seizures. So first of all, I must give you my disclosures. You will see a number of pictures of animals during this talk. So I don't have permission from the animals of any of the images. If there's any children, I have had permission from the children and their parents. So the definition and epidemiology of febrile seizures, the official definition is that it is accepted generally to be a seizure accompanied by fever, but the temperature should be more than 38 degrees centigrade. That's the central temperature. And without central nervous infection, that should definitely be excluded. And it typically will occur in infants and children aged 6 months to up to 6 years. And you'll see in some reports 5 years and others 6 years. Febrile seizures occur in 2 to 5% of all children. So this makes it the most common convulsive event in children younger than 60 months of age. So there are two key definitions to be aware of, because these are the things that have direct implications on quite diverse management approaches for our patients, is to be absolutely sure if you're dealing with a simple febrile seizure. So in this setting, it will be under 15 minutes. Some reports say 10 minutes, but the reality is the vast vast majority will terminate within 1 to 2 minutes, that it will be a generalized tonic-clonic convulsion, there will be a clear focus of infection, and it should be isolated to one illness. So this is the biggest catch-out that I have seen, where there are recurrent events that appear to be 1 to 2 minutes, but in fact they occur sequentially during the same illness or 24 hours, and in fact are suggestive of a more complex setting, which is your complex febrile seizures. So these typically are in fact prolonged. They may be focal or generalized, and usually greater than 15 minutes long. The recurrence within 24 hours is a really important marker to pick up and detect, and there may or may not be associated post-ictal neurological abnormalities, either with prolonged obdentation or a Todd's paresis. So when we think about the two conditions, simple febrile seizures represent about 70% of the children that present with febrile seizures, and they will be generalized tonic-clonic seizures under 15 or 10 minutes, depending on which bit of the world you're in, and there should be no recurrence within 24 hours or within the same febrile illness. Whereas a complex febrile seizure represents about 30% of febrile seizures presenting to the ER. They may have focal features. They will be longer than usually at least 10 minutes, and there will often be 2 or more events occurring within 24 hours or the same febrile illness. So our priority as clinicians is to work through certain strategies. So to recognize where there might be an underlying CNS infection. And in our setting, that is absolutely critical, because we know that infections drive many of the admissions that we see in our acute care environments. So the biggest fear is clearly a meningitis or an encephalitis. I've slipped in here something which is not an active infection, but a post-infective scenario, and that's ADEM, because that can often muddy the waters and should be considered where things just don't quite add up and you think there might be infection, not sure, the child appears really sick, there are seizures and the child is obtunded, and the family say that the kid had been unwell with a febrile illness shortly before, and this may be acute disseminated encephalomyelitis. So this is really critical that we actually consider these conditions and recognize where there's something more complex might be happening. So then you need to consider in your CIV, especially if events have occurred more than once, could there actually be an epilepsy syndrome going on in this patient? And certainly our biggest fear as pediatric neurologists are missed syndromes such as Dravet syndrome, which carries a terrible diagnosis, and early intervention can improve the outcome significantly. So we encourage in our emergency department that any infant that presents under 6 months of age with a prolonged febrile seizure, which hasn't really got a clear explanation about why it's happened, that they get red flagged to be screened and considered for Dravet syndrome, so that we can actually work out whether they need a different targeted approach to care. And then the milder end of the spectrum are your GEFs plus, so the generalized epilepsy with febrile seizures plus, and then sometimes the genetic epilepsy with febrile seizures plus. And the reality is that what we want to do is do no harm, ensure the child is as safe as possible. So we think about the impact of these events and to be aware that where it's not a simple febrile seizure, could these recurrent or prolonged events lead to secondary sequelae? And certainly the impact of subsequent temporal lobe epilepsy is something that is a real concern. So this is, it looks like quite a confusing table, but actually it's a really nice figure to unpack mentally when you're thinking about these patients. So the majority are going to fall into this group. These are your simple febrile seizures. They're presenting between 6 months and 6 years of age, and they improve with time and will settle with time. But you also have situations where febrile seizures are occurring. They may be typical, or they may be simple or complex, but actually they're a prelude to the sequelae of developing epilepsy later. And some of these kids will get a temporal lobe epilepsy. Some of them will manifest as other syndromes. And there isn't very much you can do about that in this setting. And then there's the setting where, in fact, it's an early warning sign, and this is really an indication of where the Dravet syndromes fit in. So the epilepsy is actually a manifestation, and the seizures are part of the core factors to it. So Dravet syndrome falls into this, and as time comes on, more afebrile seizures dominate. And then you may just have a child who just has epilepsy, and the fever is just a provoking feature. And this is a case of then counselling the family and planning and being aware that these are actual epileptic seizures that are occurring, and the fever just triggered them. So how do we then approach this? Obviously taking a really, really good history and a really good examination, and doing that great detective work that South African doctors are brilliant at, and thinking about if there's any concern of an intracranial infection or the child's otherwise unwell, then you really should be thinking about admitting, investigating, and doing targeted treatment. But you should only be requesting the lab investigations specifically for around the provoking factor, so the fever and the other clinical features. So antipyretic measures are often pushed and encouraged. They're only going to provide symptomatic relief. They won't make any difference about whether a seizure recurrence is going to occur. And for a simple febrile seizure, there is no indication to be requesting an EEG or neuroimaging. In our setting especially, we must always be thinking, should I be doing a lumbar puncture? And be sure that you've excluded all factors that might make you think you should be doing it. So if you've got an infant with an unexplained fever, you've got any meningeal symptoms, you've got preceding antibiotics that might be masking an underlying infection, you should be thinking about doing an LP. Obviously checking it's safe, and remembering that if you have made a diagnosis of a simple febrile seizure, there is no indication to put the child through a lumbar puncture. So this is our greatest fear. This is actually where it comes down to the paradigm. You have simple febrile seizures representing 70%. You should be reassuring and not intervening. But actually, there are situations where they are complex febrile, and this equates to febrile status epilepticus. And how do we understand what do we mean by this? So the definition of status is a condition that it results in the failure of mechanisms responsible for seizure termination, or from the initiation of those mechanisms leading to abnormally prolonged seizures. And this is now coded as time point T1. So it's a condition that can have long-term consequences. And at that point, it's now referred to as time point T2. So in your emergency department, you ideally want up on your board where you log what treatments are given, your T1, whether you've hit it, and your T2. So this, if you hit T2, can include neuronal death, neuronal injury, altered neuronal networks, and this really depends on the types of seizures that occur, but it is not good news to hit that point. So what does that mean? So if you've hit T1, this is regarded as 5 minutes for generalized tonic-clonic seizures, and this relates to continuous seizure activity. So those of us back in the day from medical school will remember being told our status is 30 minutes. Well, the concern with that was that people didn't intervene until 30 minutes hit. People didn't realize that it was something they should be preempt until 30 minutes hit. So now they've put this marker in that actually status starts from 5 minutes of continuous seizure activity. And then your time point 2 is when you know you're getting into trouble because there's potentially long-term sequelae. So this is your 30 minutes.
Apology, Professor Wilmshurst.
Yes.
I'm not sure. I've got a blank screen on your presenter screen. Has everybody else?
No.
We
no.
can see your
No, we can see the screen.
Oh,
okay. Sorry, Professor Ventless. Thank you. Thank you. It must be on my side.
Don't worry.
Thank
Oh,
okay.
Teams is doing funny things
we're
today.
seeing the screen. The screen
Excellent.
is on our side, yeah.
Thank you, everybody. Hi, Alison. So these time points, I have to say, I mean, they're really good to have them in because they give us pointers and at least give us directives to start setting up protocols and approaches to care. But they are, in fact, based on incomplete animal experiments and fairly limited clinical research. But I think with having this stated and with having these definitions in place, then it means that we've got a starting point. It means that actually we can start doing studies where there's going to be directness and consistency that will then help us with how we do better care. Because the issue is that most seizures, in fact, as we said, they're going to stop in 5 minutes. So actually, in most situations, we're not in this position. But if they don't, and if you're not ready to intervene, then the longer the seizure goes on, the harder it's going to be to control the event and the worse the outcome. So this is typically driven by the underlying etiologies as well. Mortality is listed about 2 to 4%. These are worldwide data. When you deep dive into Africa, certainly parts of Africa where cerebral malaria is so common, then you actually see the figures are much, much higher. So in fact, it's critical to recognize and get in early with effective interventions. So how is there disparity between low income and high income settings? So when you look here at the data of predominant etiologies for convulsive status epilepticus, in fact, in a low-income country, they're driven by febrile seizures. So in our settings, we have incredibly high levels of respiratory infections, gastroenteritis, and a whole myriad of other infections, including malaria, across parts of the continent. Whereas in a high-income setting, their typical factors that they'll be managing are breakthrough seizures from children known to have epilepsy, driven by fever, and low levels of anti-seizure medications. So this is some eloquent data that was done, studies a number of years ago now, but the information that came out of it was really useful. So this was in the States, and they recruited about 200 kids from 5 centres in the 1 month to 5 year age group. And these kids presented in febrile status epilepticus. And the study question that they had was actually quite specific. They wanted to know if there was a relationship between febrile status epilepticus and hippocampal sclerosis. So that's where they started, and that's all they wanted to know. But actually, the study was so well designed, and the data collected so meticulously, they gleaned a whole ream of really useful, clinically relevant information. And these are some of the data that came out. Certainly that the most at-risk group are your youngsters. The young children, the younger they are and the lower the temperature, are more risk than older children, where tolerance comes up as our network starts settling in. And they felt that this was due to impaired regulation of seizure duration. What they also found was that obviously these kids all had a CSF done, and an abnormal CSF was never normal. The finding of an abnormal CSF immediately identified an underlying CNS infection or other inflammatory process. So what should we be doing in these children that present with complex febrile seizures that are prolonged? So what is the evidence that tells us how we should be managing them? So there's really good evidence to support the use of benzodiazepines. And I hope that all of you in your settings have this in place and have a protocol in place that you use that actually works well for you. So the strongest evidence comes out for IV lorazepam, but this has to be kept in a locked fridge. And that's not always viable for all of us. And in fact, there's good evidence for many of the other benzodiazepines. And so I would really encourage you to have a protocol and have in place the agent that works best in the unit that you're in, where you have the best sustainable supply and where you're all really confident with the doses that should be given. And in fact, even outside the settings where setting up intravenous injections is possible, there's really, really good evidence to support that other modes of delivery work well. And transmucosal has been driven very well across the continent and, in fact, the world. So intranasal midazolam and buccal midazolam, they're really good studies to support its use. So if you're in a setting where you're not confident with setting up lines in children, you don't have facilities, you can equally start early intervention with actually enabling these routes of care delivery. If that doesn't work, then you're unfortunately heading into level 2 intervention. And that's when it gets a bit messy, because the studies really are not adequate and have not been done. So in many parts of the world, the 2 go-to agents have been phenytoin and phenobarbital. And there are problems, unfortunately, with both of them. So phenytoin needs to be delivered intravenously over 20 minutes with a cardiac monitor through a large vein and not mixed with glucose. And I can't tell you how many units I've been through where I've seen it injected into a bag and somebody doing a slow push. Phenobarb's a lot more easy to give. You can give it quite quickly as a push. It's got a really bad press for being associated with respiratory and hypertension, but actually we have had minimal problems at Red Cross with this, and it's typically driven by previous overdosing with benzos and the underlying etiology. So both agents, as I said, have been used widely. There's also been problems with access to phenobarbital. It's not made in South Africa anymore. We have to import it. And the trouble is the studies that have been done, comparison studies, are small and very few in children. We did a study at Red Cross because our anecdotal experience had been that we quite liked using phenobarb. We thought it worked well. And indeed, when we did it as a proper study, we found that it terminated convulsive status epilepticus more quickly and more effectively than phenytoin. And of equal importance, it resulted in less children being admitted to the intensive care unit. The problem is most of the other studies that have happened have not included phenobarbital in the mix, but there has been quite good studies looking at comparisons with phenytoin, and unfortunately it comes up as inferior pretty much consistently in most of the comparison studies that have been done. So what about levetiracetam? So this is the, I don't even know if you can call it the new kid on the block, but it's been around and it's getting a firm foothold and really exciting, driven partly through the Intersectoral Global Action Plan against epilepsy and other neurological disorders. The WHO has been supporting expansion of needs of care for people with neurological diseases, and levetiracetam is now part of the WHO's essential drug list. So that's really exciting for access, for another agent in our arsenal, and hopefully a reduction in price. So these were the studies that were done, again, really well-designed multi-center studies, looking specifically at the comparison of the commonest agents used worldwide for management of status. And in high-income countries, this is levetiracetam and phenytoin. So this is the Ellipse study. It was based in the UK. And what they found was, in fact, there was similar efficacy for both agents, but levetiracetam was probably easier to give, and they thought had a better safety profile. Similarly, the concept study, this was performed in Australia and New Zealand. So all these studies were happening about the same time. They were all competitively trying to reach the endpoint. And it's actually in some ways reassuring that I'll tell you all the results were very similar. So they also found that levetiracetam, in fact, was not superior to phenytoin for a second-line agent of status epilepticus. And then similarly, the ESET study in the States, this was adults and kids, but they had a large number of children and they found similar efficacy. So they compared levetiracetam, fosphenytoin and valproate, same efficacy basically across all three agents. And then some other smaller studies that happened doing similar comparisons, interestingly found that although they found valproate and levetiracetam to be safe, there was some long-term adverse events more in the valproate group. But basically no statistical evidence across any of them. So this hopefully helps you with your protocols that you might be developing for what's available to you in your units. What is then the overall pooled evidence? So this is from the American Epilepsy Society. And as we said earlier, so the benzodiazepines in fact work well, but in fact a second-line therapy, we're not sure, and there's no data supporting their role as third-line therapy. And so then when we're heading into that third-line intervention, this is basically a disaster. It's refractory status. It's disastrous for the brain. You're looking at resistant seizures. They've probably been exacerbated by whatever the underlying cause is. And then you've also been getting the secondary complications from the drugs. So now you're dealing with the hyperperfusion and the respiratory depression. So these are all affecting brain perfusion. And so this really is a crisis. So are there any guidelines that would help us for how we should optimally manage these patients? So refractory convulsive status epilepticus, depressingly, we just really don't know. And you can see this myriad of agents that were explored and considered, but actually they didn't really have strong evidence to tell you that any of them are the ones you should be using. They revolve back to the convulsive status epilepticus that we said just before, so the 30-minute goal, and said that, well, you should probably be looking at levetiracetam, valproate or fosphenytoin, phenytoin, but they don't actually know whether these would then translate into having roles for refractory convulsive status epilepticus. And then in many of our settings, it's depressing that we know we have these protocols, but actually sometimes the drugs we should be using just don't work. And I think there's probably some good reasons for this. So in fact, benzodiazepine resistance is listed as being as high as 44%. So when we analyze this as a study we did a few years ago, the interesting thing we found, and this is highly relevant to our setting, is that when there was a long delay in the child reaching the emergency unit, that group seemed less likely to respond to benzodiazepines. And in fact, all of the patients that presented an hour into seizing The benzos did nothing. So that really gave us an indicator about not delaying more aggressive interventions. So the time of intervention, as we said, it gets harder to control the longer you go, and benzodiazepine resistance gets more marked the longer the seizure occurs. And that doesn't seem to be driven by the etiologies. What was very clear is that this is the group that's more likely to end up in ICU, because obviously the interventions you're doing become more aggressive and the dosage of drugs you're giving is more. The other thing that came through from the this is the ESET study, is that they went back and they looked at what should have been the standard intervention. So everybody that went into it had gone through level 1 intervention. So they went back and they interrogated, had the level 1 intervention been done appropriately, the benzodiazepines? And this is really worrying. So this is in a resource-equipped setting, and they found that 76% of the benzodiazepine given doses were wrong, and 81% of the lorazepam doses for the first dose, and then the standard intervention with a subsequent dose. So if you're getting it wrong at level 1, it's not surprising you're then in a mess moving forward for your subsequent management. So again, it comes back to make your diagnosis correctly and have your protocols up clearly. And ideally, you have a whiteboard up where you calculate your doses and you document what you're giving, and everything is logged and everybody knows what's going on. So what happens after you've dealt with this child who's had a febrile seizure? What would the post-event management be? So which kids should you keep in? And the recommendations are, if they're under 18 months of age, if it's a complex febrile seizure, if there's no identified focus of infection, if they are currently or receiving antibiotics, and if there's high parental or caregiver anxiety. So these are based from the NICE guidelines in the UK. So many of you may know, and in fact, I think quite a few people on the call, we run these pediatric epilepsy training courses. And so some of the statements from this are extracted from that course because they are so well screened and elucidated. But we've run these courses in many parts of the world. And when we established the courses, we tried to verify that the content was applicable in the settings that we were providing the courses, i.e. Africa. And it's very interesting, certainly for these conditions, how much commonality there is across the world. And in fact, this was a high income setting recommendation that we felt was still completely applicable to the setting that we work in. And the families, it's incredibly scary having your child having a seizure in front of you. When the families talk about it, they think their kid's going to die. They think it's the most horrific thing for them to go through. So counselling the families is absolutely essential, and to remember this. And the questions they might ask: will it happen again? So you can give them a broad figure. So the chances are, yes, it's reasonably likely it'll happen again, and the figures are about 30 to 40%. For the families that want more precise answers, the younger the child, the greater the chance of it happening again. So for those under 12 months of age, it'll be about 50% will recur. For the over 3 years, it kind of drops to about 20%. Remembering that complex features must be taken out of it. They're not a factor you can measure. And then if the family really want their accountants and they really want you to be very precise, then in fact you can add in other risk factors. So if there's a family history of febrile seizures, if there's a previous history of febrile seizure, if the temperature was below 40 degrees at the time of the seizure, and if there was a short duration between when the fever started and the fit happened, then those factors go into the increasing the likelihood. So you've got none of the factors, you can say to the family, okay, 4% chance it'll happen again. If you've got all of the risk factors, then it goes right up to 76%. So for most families, I don't know, they actually want that quantification. They just want to know, is it likely to happen or not again? And then this question, so in the old days, most of these kids would end up on phenobarbital. That's not good practice. And in fact, those children from the 1980s were the ones that were used to study the cognitive impact of phenobarbital on the brain. And they showed that chronic treatment with phenobarbital in children who had febrile seizures had an IQ drop of 8 points. And when they stopped the medication, then there wasn't a full return to normal. So I'm begging you, please don't automatically start anti-seizure medication. So regular or intermittent anti-seizure medication is not recommended. Simple febrile seizures themselves are not harmful to the child, that there's a high risk of adverse events, as I explained to you, from the anti-seizure medications. And in fact, the other concern is there may be something evolving or building up, and you don't want to mask that. You want to be very clear about what you're managing. So you don't want to miss informative clinical features. So you treat what you know you're treating. So would it make a difference if you gave antipyretics really early and acutely? So many of these families are, in fact, given quite a hard time because they're told you didn't get the antipyretic in quickly enough, you didn't damp sponge. Well, in Finland, they did this beautiful study because, in Finland, nobody moves outside. It's the hardest language to speak. So they screened all these children and they gave placebo to half of them and they gave antipyretics to the others. And in fact, they found there was no difference in who got a seizure recurrence and who didn't. So it's not that you shouldn't give it, it's just that you shouldn't tell the family that it will stop a febrile seizure occurring. So there's no evidence to support acute interventions will prevent whether subsequent epilepsy will occur. So the family do ask, then, is my child going to get epilepsy now? And the vast majority of febrile seizures are not associated with the development of epilepsy. There's a 3% risk of developing epilepsy by 7 years of age and 7 by 23. So this is slightly more than the national population. The risk factors that would emphasize this is if you've got prior neurological status issues, if you've had a history of afebrile seizures in a first-degree relative, and if you've had a complex febrile seizure. And you can again quantitate those risk factors and give the family a little bit more information. But in most settings, reassurance is the important approach to take. And what would you say to them when you send them home?
What do you email?
So first aid advice. Obviously, you want them to still give antipyretics. The kid probably feels terrible. So this is for supportive care. One of the biggest disasters is excessive use of fans, tepid sponging, cold baths, because what this tends to do is reduce the surface temperature and then the core temperature then just goes crazy and can potentially exacerbate the state and how the child feels. You should consider rescue medication if the febrile seizure has been prolonged. And we certainly encourage that at Red Cross for children, especially if they've ended up on ICU and they live a long way away, because the family, as we can see, the earlier the intervention, the better. So rescue medications would be given if the events have been more than 5 minutes. And I also chat to families if they've had recurrent events more than 3 times and they're really, really super anxious. So immunizations should still continue. There's no reason why it shouldn't be given. Who should you be following up? So more than 3 febrile seizures within separate illnesses, there's really got to be a red flag that maybe there's an underlying epilepsy going on. Doesn't necessarily mean it is, but you need to be thinking about watching these children. So I would rather watch them and counsel the family than dive in with anti-seizure medication. Kids that are under 6 months of age and over 6 years having febrile seizures, febrile status epilepticus, febrile seizures that have focal seizures, and febrile seizures that are not tonic-clonic. So overall, our goals should be obviously terminating the seizure if it's still ongoing and making sure that we have excluded critical differential diagnoses, that we want to investigate in the fever etiology and be focused on that rather than worrying about the seizure, and that we need to provide adequate counselling to the family. So that clinical approach and prognosis is really driven by the subtype. So where you have a complex or febrile status epilepticus, this is going to require closer care than, in fact, the vast majority, the other 70% of children who have simple febrile seizures and will carry excellent outcomes. So febrile seizures are the most common convulsive event in children younger than 60 months of age. Simple febrile seizures will have no long-term impact on the child. Most children will not have recurrent febrile seizures, and most children do not develop epilepsy, and that anti-seizure medication, regular prophylaxis, is not recommended, and that rescue medication should be considered for children who have prolonged febrile seizures. Thank you. Any questions?
Prof, that was such an amazing talk. I haven't in a long time listened to someone who has made it so simple, so succinct, and is so knowledgeable on the subject. And I really appreciate your input for our hospital teams. We have over 200 people online today, and hopefully 200 people who have a little bit more knowledge on febrile seizures. I've been an emergency department nurse for over 30 years, and it's always been the most frightening presentation, not only pediatrics, but febrile seizures in peds, because you just are so uncertain. And as you say, the fear of the family and the distress of the family being a huge impact. I'm sure there must be questions. I see a lot of your colleagues online as well, and people I haven't seen for a long time since I was in peds. But there aren't any in the chat, and we would encourage anyone who has a question to please ask it directly.
I think, thank you so much. Thank you so much. It was what an incredible talk, and thank you for your time today. So yes, just encourage everybody for questions now. And Professor Wilmshurst, can you stop sharing, and then everybody can see you even more. So yes, I'd like to reiterate from Mandy. Thank you on behalf of Epilepsy South Africa, Professor Wilmshurst.
I'm trying to work out.
It's a great start. Just where you did share, Prof, there should be a little sign there that says stop sharing, but it's okay. It's not the end of the world. Are there any questions? I'd like to please know if you guys will have a webinar about PCDH19 epilepsy. Prof?
I don't know. I mean, we could do. I have to say, access to epilepsy genetics is like a real problem in South Africa. So if you've got private medical aid or the family willing to pay, they'll get a diagnosis. I would suggest that it's not done specifically about that. It might be more useful to do it on the DEEs in general, because there's such issues around targeted precision therapy. Because I think it's important that as clinicians, I mean, certainly in South Africa, that we don't have the luxury of homing in on a particular subsyndrome. We actually need to step back and, if you like, see the wood for the trees. So I think if we did a webinar that we would include PCDH19, but I think that we would be better to do it on the DEEs and talk about precision therapy and the implications. And I kind of alluded to that when I touched on Dravet syndrome.
Thank you, Prof. Maybe it's another opportunity for us to set something up and have a follow-up, maybe sometime in a month or two. Thank you. Appreciate that. Are there any other questions?
I've seen Gail put up a really important point. So if you
Gail?
want, I mean, I can just say it because she's made the point. It's really important. So if you liked this talk, all of you, I'd be interested to know how many of you have attended a PET course, because if this talk was useful to you, then imagine at the PET course, imagine that 100. Oh, here's a hand up. Imagine 100-fold, because actually the PET course covers the whole remit of approaches to epilepsy in children. And we're in the process of doing an adaptation for adults as well.
Thanks, Joris. Yeah, thanks, Mandy.
Morning, Sister Una from ICU, up from ED in Kroonstad. One of our sisters just typed a message. She wants to know what is the rescue medication.
Yeah, I was a bit evasive about that. So, it's usually benzodiazepine. It varies where you are for what you use. So at Red Cross, we usually use Ativan, so just a little Ativan under the tongue. In Japan, for years, they've used Rivotril drops. And then in the UK, they use midazolam. But it's the thing with resource equipped settings, and in private practice, you might be able to get this. They've got these fantastic applicators that are really user friendly. But in our setting, we've usually only got the IV formulation, and I can't imagine a family with a kid fitting, and it's bad enough when we expect them to give PR diazepam. But it's typically an IV vial that's got to be snapped open and drawn up, and whether you're giving a medicine PR like we used to with diazepam, or intranasally with midaz, or sublingually, I just think it's a disaster waiting to happen. So our preference at Red Cross is that we try to use Ativan sublingually. I know there's been supply problems, so I hope we've got enough in the country at the moment. But to be honest, it's why I was saying have a protocol in your unit where you've covered all of that and where you know that your pharmacy will guarantee supply. Because then you have consistency and people don't stuff up with what they deliver and what they do. And then if you do issue rescue medication, for God's sake, make sure that you've counseled the family how to do it and that they've done first aid, because the last thing you want to do is give the family a medication that you know is a respiratory suppressant and the child has a respiratory arrest before arriving at hospital. So it's a responsibility and a decision to actually deliver them with rescue medication.
Thanks, Prof. There are 5 hands up and then 6 hands up, and I see a question. So let's take the first hand from Michaela. Michaela, please go ahead. I don't see Michaela want. Oh, there you go. There you go.
I was actually putting my hand up for being interested in doing the PET.
Yay! Okay, yes. What you have to. So
thank you for a question.
Yeah, I actually don't know when the next one is that we're doing, but we will do one. We usually do a couple a year. But if you look on the Panda website, we always have them advertised up on that.
Okay, sure. Thank you so much.
Thank you. Bye. Thanks. Then there's Albert. And Albert?
The hand was also for the TED course that I've done. Thank you.
Okay,
awesome.
Albert, you can
well
take
done.
It down.
Well done, Albert.
I've never heard of the PET course, so maybe I'll also do it, Prof.
Yeah.
Linos or Linos?
Hi, thank you, Prof. Can you hear me?
Yeah.
Yep.
Hello.
Okay, just 2 questions, Prof. One is that I'm in Bulawayo in Zim. Sometimes we don't have phenobarbital. I'm talking about status febrile here, and is in the IV form. Is there any evidence for the oral? Oftentimes we've had to use the oral form via an NG tube. That's the first question. Then the second question is about how, let's say we have a child who has febrile status, and you start with the protocol that you've written up and you follow it. So you start with the benzos, and then you go on to phenobarbital, and then you terminate the seizure. Now let's say there's a recurrence of status. How often do you repeat the cycle, or do you just then go on to phenobarbital, for example? Then my last comment was just
yeah. I'm trying to remember all your questions.
Was just,
okay.
Thank you. My last comment was just that on what you're talking about. I think it's the ESAT study. You're talking about how when you delay giving the benzos, then your success in terminating is going to be quite limited. And I've actually observed that in some of the patients here, they present late. Often it's a transport issue. Sometimes it's a knowledge issue. And like the last case we had was a child who was fitting for actually 3 hours before they came to the hospital. Yeah. So it's quite interesting that it's in the studies, because it's something that we noticed. Thank you.
So Linus, thank you. Okay, so number 1, oral phenobarb. Yeah, so we had exactly the same problem as you, that we lost access to it. So we actually did a study, and in fact, you will get therapeutic levels within 1 to 4 hours. So that doesn't really help you in the acute setting, but it is basically another mechanism to get reasonable levels on board. And so we in fact added it into our protocol when the intravenous phenobarbital went away. And then what was the second question? Oh, you're blank now. And we get
I was talking about repeating the protocol.
Oh yes, and then so the repeating the protocol, that's a really good question. So probably at about 24 hours in, we would restart the cycle. If they are, it's within, say, the first 5 to 6 hours, we would probably just reload with phenobarb if you've got it, or whatever our next second line agent is. To be honest, it's a mess. And it's driven by the underlying etiology. So when you're getting recurrent seizures like that happening, your responsibility is to ensure brain perfusion is okay, and to actually target actually the symptomatic state of the child as a whole. So I get less excited about the seizures and more excited about trying to get whatever is driving the seizures under control by that point. And then, yeah, the issue with delayed, I think that's a real issue in our setting, that lots of the kids take a long time to get to us, and we suffer the sequelae of that in a big way for control.
Thanks, Prof. Just before I take any more hands, Jolene Swart had a really good comment. Thank you. Great talk. My daughter was diagnosed at Red Cross with a big heart, and we would love more talks regarding epilepsy in general. And then there was a question from Aisha, with a child that presents with recurrence of complex febrile seizures, more than 2 to 3, would you consider starting anti-epileptic maintenance?
I want that child in my clinic or in the nearest pediatric neurology clinic to unravel what is going on, because I want to make a diagnosis. So it's likely that I would, but I would be extremely concerned that the child's got a Dravet syndrome or some other epilepsy syndrome. So the diagnosis is critical. It's not the starting the anti-seizure medications. You do want to do appropriate therapy, but you want to do the correct therapy in the correct way. So you need a diagnosis.
Thank you. I hope that answered your question there. And then one more from Lucine. Prof, please make a comment on febrile seizure plus for the older children beyond 6 still presenting with febrile seizures.
Yeah, so this depressingly is epilepsy, and this is an epilepsy syndrome. It is in the spectrum. So the worst end of the spectrum is Dravet syndrome. These are the little babies, infants that present with prolonged febrile seizures and subsequently have significant cognitive impact. At the other end, there's a very mild form. Some are linked, some aren't, but it's regarded as a spectrum. So febrile seizures plus, they may well have had febrile seizures that are recurrent through childhood. They might have the odd afebrile seizure, and they generally persist beyond 6 years of age. The natural history is that it will normally settle with time, but it can be quite frightening and frustrating for the family, because the other seizures that come in can include sometimes drop attacks and myoclonus. Treatment, again, it should be managed by a paediatrician with epilepsy experience or a paediatric neurology service. And the actual treatment regime, so in kids under 10, we would probably still use valproate and sometimes add on lamotrigine, but we do it very carefully and very gently.
Thank you very much, Prof. I think I saw 1 or 2 more hands, but I can't find them now. Can anybody help me with the hands?
I'm looking as well, Mandy.
There's nothing up at the moment.
Alutre, I don't know if you know your camera is on, and we're getting a beautiful vision of you walking on some campus somewhere.
I'm really jealous, because I missed my morning run this morning. I think some other people managing to get out and manage to do both tasks at the same time. It's very impressive.
Yes, Alutre's having a very big walk there. I don't know where, but it's in a campus somewhere. Prof, I think Thabo Bisiwe had one last question, and I'd like to just take that as the last one so that we can allow you to go further. Thank you. Thabo? Thabo, you had a question?
Sorry. Hi, can you hear me now?
We can, yeah.
Yeah, okay, so hi, Prof. Great talk, Prof. I think my question is probably related to the syndromes, especially the Dravet's, and the other ones. My worry is that I think we've seen quite a lot of the kids that we've got recurrent, febrile seizures and at an early age, and I think also you can see that there's actually developmental delay now. There's all the other issues. How do we get access? Is there any hope of getting access again in South Africa in terms of genetic testing and really confirming if the child, has got a particular SNA1A or whatever gene defect that the child has? Is there any hope in the near future, or at least in the coming months or years or something like that?
Yeah, thank you, Thabo. So Thabo knows that we did a study at Red Cross through UCT with Alina Esterhazen, who's a molecular genetic scientist, and she set up next generation testing at UCT and demonstrated that we could actually do it and run it. And with the end of the study, the funding ended. So what we're doing now is Mark 2, and we're now trying to set it up and then do a rollout through the NHLS. So having demonstrated that obviously there are epilepsy genetic patients in South Africa and Africa, and that it has major implications for the targeted and early intervention care that we give them, we are now putting forward a case to actually roll out access to that service as well. And so we've been trying to run it on a named patient basis, which is quite tedious, but we just want to keep the emphasis up. But eventually we're hoping that NHLS will make it actually a viable service that's accessible for any specialist to actually refer a child of concern.
Thank you, Prof. I think the last comment, and then we'll thank you so much for an excellent talk. I'm going to endeavour to set up the talk for you again on the sort of the genetic side of things and the more complex side. One last comment from Kiran Pabu is that experience in the state sector is that they do a lot more LPs than necessary. How tragic.
Mm.
Real defensive medicine. Hey?
Mm.
Yeah. Okay, well, hopefully whoever listened to this, there were over 55 doctors on the talk, 60 doctors and over 200 people on the talk. They'll go away with a little bit more common knowledge and a lot more experience. Thank you, Prof. We could have had you here for 4 hours and we wouldn't have, it wouldn't have been enough. And we really do appreciate you kicking off our attempt to improve education in epilepsy. Thank you.
Wonderful.
Charlene? I don't know if you want to finally, and happy Valentine's Day for yesterday, Prof.
Yeah.
Thank you, Mandy. So yes, thank you. That was incredible, Professor Wilmshurst, and just so exciting for us to now be able to have addressed febrile epilepsy this morning during this wonderful week. So yeah, happy Valentine's to everybody from yesterday, and thank you for joining this webinar this morning and starting off your day on a Thursday with more knowledge, more things to think about, and more plans to upskill and carry on being in service to South Africa. So that's all. That's from us, from Epilepsy South Africa, and thank you to Netcare, the wonderful partnership, and for Mandy for all the work. And from my side, have a wonderful Thursday.
Thank you. Thank you very much.
Bye-bye, everybody. Thank you.
Bye.
Thanks, Prof.
Bye.